Morning to morning, ma'am. Today I am presenting my seminar on topic electrolyte imbalance. Electrolyte imbalance basically is because of sodium either hypernatremia or hyponatremia, or potassium hypokalemia or hyperkalemia, or calcium hypocalcemia or hypercalcemia. Mainly, basically, it is electrolyte imbalance in our body is mainly due to two things: sodium and potassium. Sodium we can first of all we are going for hypernatremia. Hypernatremia means sodium concentration of greater than 145 milliequivalent per liter. The normal amount of sodium in our body is 135 to 145 milliequivalent. Above 145, it is hypernatremia, and below 135 or below 130, we can say it's hyponatremia. It is a state of hyperosmolality. Hypernatremia means sodium is increased, means body salt is increased. It can be either due to impaired thirst in a comatose patient where patient is not able to drink water, so it can lead to hypernatremia. Thirst is impaired. Essential hypernatremia. Solute diabetic ketoacidosis can also present with hypernatremia where diuresis is there. Means sodium is means water is excreted out, and in body only sodium is left. Non-ketotic hyperosmolar coma. Mannitol also increases. Mannitol is a osmotic diuresis. Mannitol. Excessive water losses, like in diabetes insipidus, is mainly nephrogenic diabetes insipidus or neurogenic. It mainly ADH hormone. If ADH hormones is more and more increased, then lead to diabetes insipidus. Neurological clinical manifestation. How a patient of hypernatremia can present predominantly. Patient is mainly restless, lethargy, hyperreflexia is present mainly. Restless and hyperreflexia. Whereas in hyponatremia, patient is hyporeflexive. No, means all. In here also, patient can be in altered mental status also. Seizures can be there, coma, and ultimately death can occur. Hypernatremia, basically, very patients are less as compared to hyponatremia. Old age patients, hyponatremia is more common, but hypernatremia is less common. We for hypernatremia, if there is hypernatremia, we should first check for back. We should check for the drugs we are giving. If we are giving any solute diuresis like mannitol, it can lead to hypernatremia. Treatment of hypernatremia is aimed at restoring plasma osmolality to normal as well as correcting the underlying cause. Water deficit is calculated. Free water deficit, plasma sodium in 140 minus 1 into total body weight. Correction should be done over 48 hours with hypotonic solution such as 5% dextrose in water. In hypernatremia, what we can give is free water, like mineral water, either thing. But in places like Meerut or Ghaziabad and all, we can't give this free water because it also has a salt in it. We have to restrict this salt, so we can't give. We can give D5 dextrose 5 water. It has zero salt, zero sodium. We give N by 2 also. N by 2 has has sodium but lesser amount. 131 is in NS. It is as 65 milliequivalent. We can give D5W or free water. Free water is best. If you are giving through RT or anything, we can give free water or mineral water to correct hypernatremia. Patient correct, and we should correct it slowly, not acutely. Uh, 48 hours in 24 hours, we can correct up to 6 to 8 milliequivalent only, not more than that. Rapid correction of hypernatremia can result in seizures, brain edema, permanent neurological damage, and even death also. In general, decreases in plasma sodium concentration should not proceed at a rate of 1 per hour, not more than 1.5 should increase. But in severe cases, severe hypernatremia patient is there, then initial 2 hours you can correct it 2 milliequivalent per hour initial, and later but main thing is that more than 8 milliequivalent correction is not done. 6 to 8 milliequivalent correction is not done in 24 hours. Main goal of treatment is sodium is less than 145 milliequivalent. Anesthetic concentration, what is done in anesthesia people, and hypernatremia has been demonstrated to increase the minimum alveolar concentration for inhalational anesthetics. It means if we are giving any inhalational anesthetic, then hypernatremia increases the MAC. Elective surgery should be postponed in patient with significant hypernatremia. Both water and isotonic fluid deficit should be corrected prior to elective surgery. Now coming to hyponatremia. Hyponatremia is more common than hypernatremia. In old age patients also, hyponatremia is more common. Sodium less than 135 milliequivalent per liter. Most common electrolyte disorder, hyponatremia. What we see here, Hyponatremia is commonly caused by cellular edema with presence of hypotonicity. Causes of hyponatremia, mainly we are giving diuretics. There we were giving osmotic diuretics, but here we are giving thiazide diuretics, loop diuretics, and other diuretics, which leads to excretion of sodium and water from our body. Mineralocorticoid deficiency also can cause aldosterone deficiency. Salt losing nephropathies are there. Osmotic diuresis also. Mannitol can cause hyponatremia, but mainly hypernatremia. Renal tubular acidosis, extrarenal vomiting, diarrhea. If patient is vomiting or diarrhea, we can see it causes hyponatremia also, hypokalemia also, vomiting. Intra sweating, burns, third spacing. Clinical manifestation: sodium less than sodium less than 135 milliequivalent. If sodium is patient with sodium more than 125 and less than 135, between 125 to 135, patients are frequently asymptomatic. Serious manifestation only occurs when the sodium is less than 120. Early symptoms are typically non-specific and may include nausea and weakness. Weakness is main thing. Patient will in hypernatremia, patient is hyperreflexive. Here, not patient is not hyperreflexive. Patient is hyporeflexive. You can say. Uh, Progressive cerebral edema, however, result in lethargy, confusion, seizures, coma, and finally death can also occur. Treatment of hyponatremia dietary correcting both underlying sodium disorder as well as plasma sodium. Correction of sodium greater than 125 is usually sufficient to alleviate symptoms. If patient is having severe hyponatremia, then we can use 3% NS, and if a patient has moderate symptom, we can use plain NS also, what we give. Uh, but if it's severe is there, then we have to give 3% NS initial. In 3 hours, 10 bottles per 10 minutes. Uh, Desired value, the sodium deficit can be estimated by the following formula: sodium deficit, total body water into desired sodium minus present sodium. Excessively rapid correction of hyponatremia has been associated with demyelinating lesions in the pons, central pontine myelinolysis. The following correction rate has been suggested: for mild symptoms 0.5 per hour, for moderate 1 per hour, and for severe symptoms 1.5 per hour. Anesthetic consideration, what can be plasma concentration greater than 130, we can skip this. Hypokalemia mainly. Hypokalemia is defined as plasma sodium. Hypokalemia means potassium. Basically potassium is intracellularly is more. Potassium in intracellularly is more. We cannot calculate the value of exact potassium every time, how much we have to give, how much we have. If we give potassium, then it goes intracellular, then it can also lead to hypokalemia. So uh, its correction is not adequate. Like sodium we can correct, because sodium extracellular is more, we can calculate it by doing the electrolyte test. But hypokalemia in potassium we can't do that, because what we give it ultimately goes inside the cell. But patient with hypokalemia, we have to find the cause of hypokalemia mainly. Basically, first to treat hypokalemia, we should know the cause of hypokalemia or hyperkalemia. Hypokalemia is defined as sodium potassium level is 3.5 to 5 is normal. 3.5 to 5 is normal. Below 3.5 is hypokalemia. After more than 5 is hyperkalemia. A decrease in plasma sodium from 4 milliequivalent to 3 milliequivalent usually represents a 100 to 200 milliequivalent deficit. Means if there is a deficit of 100 to 200 milliequivalent, but in our serum it only shows 4 to 3, but actually it is 100 to 200 deficit. Whereas potassium below 3 milligram can represent a deficit anywhere between 200 to 400. Causes: extrarenal causes, mineralocorticoid excess, primary hyperaldosteronism, Cone syndrome, renin excess, RAS system mainly you have to see, renovascular hypertension, diuresis, chronic metabolic alkalosis, GI loss, vomiting, diarrhea, ECF, extracellular fluid to ICF shift. Means extracellular to intercellular, means intercellular it has more potassium, but extracellular it has less. So it is it's hypokalemia only. Acute alkalosis, hypokalemic periodic paralysis, barium injection, insulin therapy. Insulin decreases potassium. Mainly you have to see. Clinical manifestation: most patients are asymptomatic until plasma sodium falls below 3. Cardiovascular abnormalities effects are more prominent and include abnormal ECG, arrhythmia, and decreased cardiac contractility and labile arterial blood pressure. Mainly patient comes in hypokalemia or hyperkalemia, we can do an ECG, we can easily predict that patient has hypokalemia or not. ECG is the first basic investigation for checking the potassium. Potassium is has chronic hypokalemia, there is the ECG changes are there. Here we can see prominent T wave T wave is there and U wave is coming in hypokalemia. As the severity of hypokalemia is in first picture, the potassium is 3 milliequivalent. In the second one, it is 2.6 and 2.7, and third image that it is 1.3. The more the T is ST depression, T is going downwards, ST depression is there, and U wave is getting prominent. U wave is getting prominent means severe hypokalemia. We are going towards the severe hypokalemia. We can easily detect hypokalemia or hyperkalemia both by ECG. We don't need to do any electrolyte imbalance which comes late. We can easily treat these patients. Intravenous replacement usually we reserved for patients with or with at risk of significant cardiac manifestation or severe muscle weakness because of potassium's irritative effect on peripheral veins. Peripheral intravenous replacement should not exceed more than 8 milliequivalent per hour. Means correction should not be more than 8 milliequivalent per hour. Potassium which we can give either oral potassium syrup pot chlor comes, and we can give IV potassium also. IV potassium also in by potassium wise. Dextrose containing solution should generally be avoided. With dextrose, potassium is never given. With DNS, with D5, D anything, if you are giving with dextrose with potassium, it is useless, completely useless, because by dextrose, potassium won't be able to all the potassium will go to intracellular fluid, and ultimately it will lead to hypokalemia also. So if you are giving potassium with dextrose, it is completely useless. No need of giving. We should always give with NS or something. Uh, 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 More rapid intravenous potassium replacement requires central venous administration and close monitoring of ECG is done. Intravenous replacement should generally not increase to 40 milliequivalent per day. Not more than 240 milliequivalent we can give, and a vial comes of either 15 milliequivalents come or 20 milliequivalents also come of potassium. In per liter we can give, per liter of NS, not we can give 40 milliequivalent of potassium we can give, which is given in 2 hours. Any study consideration we can leave. The intraoperative potassium should give any hyperkalemia. Hyperkalemia. Hyperkalemia is more than 5, I told you. 5.5. Back. More than 5.5 milliequivalent of potassium is hyperkalemia, and hyperkalemia is more serious than hypokalemia. Hyperkalemia is dangerous for life. If you are not able to treat hyperkalemia instantly, then patient may ultimately lead to cardiac death. And in patient of CKD where potassium is not able to secrete out, kidney disease is there, we should check for potassium, because in those patient of kidney disease patient, potassium is in excess, and that is the main common cause of causing death, cardiac arrhythmias, hyperkalemia, VT. The most important effects of hyperkalemia are on skeletal and cardiac muscle. Skeletal muscle weakness is generally not seen in ultimate potassium is greater than 8 milliequivalent. Cardiac manifestation we can see are primarily due to delayed depolarization and are consistently persistent when plasma potassium is greater than 7 milliequivalent. More than 5.5 or 6, we have to treat hyperkalemia. ECG changes, there is a widening of the QRS complex and prolongation of PR interval, and SPM will show in the image. This you can see the as the severity of hyperkalemia is increasing, there is a S wave is going down and T wave hyperkalemia. In hyperkalemia, T wave is getting tall T waves you can see. As we are progressing, the tall T wide QRS complex is getting wide and wide. This you can see. This this QRS complex is getting wide, and T wave, T is getting prominent. This is like looking like a sine wave, hyperkalemia. Treatment hyperkalemia exceeding, if it is getting exceeded more than 6 milligram, should be always be corrected and immediately should be corrected. Treatment is directed that potassium correction we see. We give insulin 12 units of insulin when D25, and in calcium gluconate we mainly we give, and with enablers with ethylene is given. Treatment cardiac maintenance, calcium 5 to 10 ml or 10% calcium gluconate or 3 to 5 ml or 10% calcium chloride partially antagonizes the cardiac effect of hyperkalemia and is useful in patients with marked hyperkalemia. When metabolic acidosis is present, intravenously sodium bicarbonate will promote cellular uptake of potassium and can decrease plasma potassium within 15 minutes. You can correct the patient. And beta agonists promote cellular uptake of potassium and may be useful in acute hyperkalemia. Beta 2 agonist can also be given. We nebulize the patient with stellina salbutamol, so to treat hyperkalemia associated with massive transfusions. An intravenous infusion of glucose and insulin, 30 to 50 gram of glucose with 10 units of insulin. Neutralizing drip is what we call it. It is also effective in promoting cellular uptake of potassium and lowering the potassium. All the potassium by insulin will go inside intracellular, and extracellular will be less, but may take about 1 hour for peak effect. Dialysis is indicated in symptomatic patient with severe referral. If you are, if by medication we are not able to correct hyperkalemia, then ultimate is dialysis. Anesthetic considerations, phenylcholine is we can done hypokalemia. Thank you.